Hello, everyone. Thank you for joining today's session on your favorite channel, Cancer Reach. Cancer Reach is an initiative by our very own oncologist, Dr. Krishnamani, to spread awareness about cancer and to help patients and caregivers access the right treatment at the right time. Many people think cancer only causes symptoms where the tumor is located, but that's not always true. Sometimes cancer can trigger unusual signs in completely different parts of the body, even before the cancer itself is detected. These so called paraneoplastic syndromes can affect the hormones, nerves, skin, blood, or muscles. Recognizing these odd symptoms early can sometimes lead to an earlier cancer diagnosis and better outcomes. In today's session, we'll break this down in simple terms and help you understand when unusual symptoms should not be ignored. Joining us today is Dr. Krishnamani, one of the most respected voices in oncology. He has been with AY hospitals here in Hyderabad for over a decade, where he is known for his expertise in managing solid tumors, blood cancers, and oncological emergencies. His journey spans international fellowships and leadership roles at some of India's top cancer centers, giving him a truly global perspective on cancer care. What really stands out about him is his compassionate and patient centered approach. He's not just a brilliant oncologist, but a trusted guide and ally for so many patients and families navigating the cancer journey. We're truly honored to have you here with us, sir.
Hello, welcome to Cancer Reach. Cancer Reach is an initiative to spread awareness on cancer. And as you said, today we'll discuss about paraneoplastic syndromes, which is very important and very often talked about in medical circles amongst doctors, but not that, what do you say, the patients and their families would probably not know much about this, or a layperson would not know much about this. So it's a very difficult and exhaustive and extensive topic, but we'll try to touch some basics on how it is and how it is useful for a common person to understand.
So, can you start by explaining in simple terms what does paraneoplastic syndromes mean?
So, cancer can spread to different organs in your body and cause problems. Suppose there is a breast cancer in someone or a lung cancer. If it goes to the brain, they may develop fits or seizures. They may become unconscious. Okay, so this is a brain issue which is due to the lung cancer or the breast cancer, which is because it has spread to the brain. If you do a CT scan or an MRI, in that MRI, you will see brain lesions. Paraneoplastic means the patient has neurological problems. That is, he or she is unconscious or in coma, or they have weakness, or they have seizures, or they have nerve issues, or they have paralysis, etc. due to cancer. But the cancer has not spread. That means when you scan them, do an MRI or do a spinal cord MRI or a brain MRI, that MRI is normal. It does not show spread of the cancer. But the patient has symptoms and the patient has cancer also. So I have cancer, I have certain neurological symptoms, but my cancer has not spread to the brain or the spinal cord, at least on the scans. So, to put it in a very simple way, cancer spreading to the brain is metastasis. Cancer sitting at one place and pulling strings from a remote corner is paraneoplastic. So, paraneoplastic means your cancer is there, it is affecting a distant organ without spreading there. That is paraneoplastic.
Sir, how common is this syndrome in patients?
So paraneoplastic syndrome is seen in, it depends on series to series according to literature. In some case series, it is as high as probably 5 to 7%. In some case series, it is reported as less than 3 or 4%. More common in certain cancers like small cell lung cancer, lymphomas, breast cancer, thymomas, etc. So no, sarcomas are rare to cause paraneoplastic manifestations. Or colon cancer is probably not that very common to cause paraneoplastic. Rectal cancer doesn't cause commonly. But small cell cancer of the lung, breast cancer, lymphomas, thymomas, these cause paraneoplastic. So if you see paraneoplastic syndromes, you should first try to see whether these diseases are a part of this diagnosis.
Sir, is there any specific age group or any specific gender which is more commonly affected with this?
Men slightly more common than women. Age group, it can be seen in any age group, but usually it is seen in the younger age group. Younger means it is seen in the age groups between 35 to 55 or 60 years.
Sir, what are these symptoms of the paraneoplastic syndromes? Typical symptoms.
So you have to divide it. You have to call them as paraneoplastic neurological syndromes, paraneoplastic ocular syndromes, paraneoplastic muscle syndromes, paraneoplastic spinal syndromes, paraneoplastic nerve syndromes, then raised calcium, then paraneoplastic erythrocytosis. We say the hemoglobin goes up very, very high. RBC, WBC sometimes go high. So rheumatological syndromes. So it can literally affect any part of the body. But what we would generally focus, or the most common paraneoplastic syndromes, are the paraneoplastic syndromes of the brain and the spinal cord, or the muscle and the nerve. So the neurological paraneoplastic.
Sir, can you say that if a person is having unexplained skin changes, those can also be linked to these paraneoplastic syndromes?
That's too general a statement. Generally, to call something paraneoplastic, you should also have cancer. But please understand, sometimes paraneoplastic syndromes can come in an individual before the development of cancer. Okay. Now, suppose there's a cancer patient, he or she has become sick. That patient has suddenly become, over a period of time, 10 days, become unconscious and all that. I do all the scans, I do everything, even CSF analysis or the spinal cord fluid analysis, nothing comes positive. I should start suspecting paraneoplastic. So to say something is paraneoplastic, first you should rule out spread from the disease, cancer. You should rule out infections. You should rule out drug-related problems. You should rule out nutritional problems. You should rule out metabolic, like sodium, low potassium, high calcium, those kind of. So when there is no infection, no drug-related issue, cancer has not spread to the brain, then you call it paraneoplastic. Number one. Commonly, I told you what all cancers you look for paraneoplastic. And what was your question on whether we
Skin
have to
changes.
skin
Skin
changes? So
changes
that
can
is
be
too
present.
broad a term. What I was trying to come to you was, sometimes you may find a paraneoplastic uh, test positive. We will come to that later, but the patient doesn't have cancer. So what it means is this patient may develop cancer in the near future. So you should look out. Generally, when somebody has cancer and becomes sick and you rule out everything, you say it could be paraneoplastic, but sometimes patient has some neurological issue, you do tests, you say that this is a paraneoplastic syndrome associated positive antibody, you scan, there is no cancer. So, in those cases, this patient already has a paraneoplastic manifestation even before the cancer has developed. So, if you keep the patient in close follow up, very soon, within 3 to 6 months or so, the cancer will pop up. So, bottom line, paraneoplastic can precede cancer diagnosis or succeed cancer diagnosis, can be present before the cancer starts or after the cancer starts. And skin changes are, what do you say, a very generalized way of telling. So, it doesn't mean anything like that.
Sir, any particular risk factors for this syndrome?
These common cancers, which I said, are some of the risk factors. The age is a risk factor, but otherwise, there is nothing specific.
Sir, can you explain about the diagnostic techniques used for detecting these?
So first, as I told you, do an MRI. If you have a neurological problem, do an MRI brain spinal cord, rule out that it is not spread of the cancer. Do all your vitamin B12, folate, vitamin D, calcium, sodium, potassium, nutritional. Do all your metabolic profile. Do all your drug profile. The patient should not be on any chemotherapies or any immunotherapy drugs which can cause uh, brain changes and all that. And all this is normal. Toxin profile. Ingested, they could have taken some toxins, ingested some poisons. If all the toxicology screen, everything is negative, then what you will do is you will do what you say, like how you do ECG for the heart, you do EEG for the brain. You do for the muscle electromyogram. Somebody may develop myopathy. Myopathy means muscle weakness. Okay, they may have progressive weakness of the lower limb from below, from the foot to the ankle, then to the thighs, legs and thighs. Slowly, the weakness will grow, and what would be initially difficult in walking finally would come to a point where they can't even get up from bed because the thigh muscles are also weak. So then you will do something called an electromyogram. You will do a like ECG, EEG, you will do it to the muscle to check if there is any activity in the muscle. Sometimes you will do a muscle biopsy, and you'll also do a CSF analysis. That is, you put a small needle in the spinal cord, take the fluid and send it for sample. And in the blood, you will do antibody testing. There are certain antibodies like anti-HU, HU, anti-NMDA, anti-amphiphysin, anti-CRMP. So this list is endless. This is not for the common person like us. It is a very specialized part of the oncology field, but I'm just giving you an example. So broadly, what are the tests you will do? MRIs or scans, toxicology screen, metabolic screen. You rule out drug-induced problems, and you will do CSF analysis and antibody. Most important, remember, antibody testing in blood and CSF. And if certain antibodies are seen, that means you have this paraneoplastic syndrome.
So typically, when does a patient consult with a medical oncologist? Like immediately after the signs and symptoms are present, or they come through referrals?
So I'll give you an example of a patient. Okay, so we had a lady who was diagnosed with breast cancer. A very unfortunate case, actually. So, a young lady, she's 54, 55. Just, just a month back, she had her wedding anniversary also, a week back rather. Completely ambulatory lady, working as a next to a CEO level position in a company, in a firm, well paying job. Recently detected diabetes. So she came with sugars of 250, 300. Recently detected a breast lump. So she came to my office. She said, just last week I had my family functions and I'm so and so. Now I have a breast lump. Somebody did a needle test. They said I have breast cancer. I have come to you. And we looked at the reports. The sugar is also high. When she was talking, I asked her, Madam, do you talk this way? She's like, hello, doctor. I have come for a checkup to you today because. So there is slurring of speech. I said, Madam, do you talk like this? Because I don't know. I've never seen you before. The husband was like, no, no, no. Recently, in the last 3 days, she's talking like this. Earlier, she was crisp and clear. Then something didn't add up. And then I asked her any other problems, any headache, any double vision, any seizures, fits, weakness in the limbs. Then she said, last 2, 3 days I'm noticing, husband said, when we got down to the car, I had to lift her. She said she's unable to get up. So now there are two problems. One is your speech, one is your muscle weakness. Okay. So this is pointing to something to the what system is it respiratory system or a digestive system? No, it is a neuromuscular system. That much though even a kid will say, right? Muscle, nerve, cranial nerves or speech related something. So I said, Madam, something seems to be wrong. Why don't we go and consult our neurologist once? Okay, because sometimes high sugars can also lead to this. You're a new diabetic, but your sugars are not 500, 700. They're hardly 150, 250. So our neurologist immediately had a suspicion and she did all these tests. And within 2 days, we diagnosed her as having paraneoplastic cerebellar degeneration. So cerebellum is that part of the brain which is in the behind, which is behind, okay, in the brain here. And the cerebellum maintains your speech output and also maintains your gait and position. You don't fall this side or that side because your cerebellum is sending signals down. Falling either way is called ataxia. That is no balance. Okay. So she had on CSF antibodies positive for the particular antibody, and we diagnosed her as MRIs were normal, paraneoplastic cerebellar degeneration because of breast cancer. Breast cancer has not spread there, but it is the responsible part. Now, slowly, slurring of speech became so bad within a matter of 2 months. Uh, this is the way the poor lady is communicating. Got it? So, why I'm trying to give you this example is It is to purely tell you how a patient presents in the clinic for what you asked me. Completely bedridden, unable to get up from bed, unable to get up even for daily activities, had to be completely taken care of. So, this is a classic example we saw very recently in our clinic of paraneoplastic cerebellar degeneration. And it is one of those paraneoplastic syndromes where you do anything, the patient is not going to recover, unfortunately, most of the times. So they become bedbound, and then, though the tumor is small, though the tumor is size-wise small, still the cancer is not killing you, but the cancer is causing certain effects in your brain, which is making you invalid or useless. That is what I would say. So this is one way I told you paraneoplastic cerebellar degeneration. Somebody may come with paralysis, slowly ascending paralysis from the lower limb. Somebody may present with shooting pains in the leg or the hands. Somebody may present with double vision in the eye, loss of vision. Somebody sudden loss of vision, optic retinopathy, optic neuropathy, or retinopathy. Cancer associated retinopathy, we say CAR. Okay, or they may present with floaters in the eye, so you should examine the eye and all that. Somebody may present with weakness of the limbs, weakness of the respiratory muscles, leading to the patients to go sometimes on ventilator also, drooping of the eyelids, especially in a disease called LEMS, we say Lambert Eaton myasthenic syndrome, muscle weakness and eye muscle weakness. So patients can present in a myriad of symptoms, in variety of symptoms.
Sir, can you elaborate the treatment for these patients?
So what we should understand is 2-3 things. So treatment is basically on treating the tumor. If the tumor is treated successfully, that is the first step. You treat with chemo, surgery, radiation, whatever. Second, treat the paraneoplastic syndrome with either steroids. If they don't work, or sometimes we use IV immunoglobulin. If that doesn't work, we do immunochemotherapies like cyclophosphamide or rituximab, immunotherapy by targeted therapies or MABs, monoclonal antibodies by name rituximab. So this depends. Why? Because some of the antibodies are directed against antigen within the cell and on the cell. So those paraneoplastic syndromes, because of antigens within the cell, they don't respond to treatment at all, like this paraneoplastic cerebellar degeneration. But the other ones could probably respond. So treatment is in the form of steroids or immunoglobulin, like chemotherapy like cyclophosphamide, plasma exchange, but most importantly, treat the primary tumor.
Sir, would I be right if I say that paraneoplastic syndromes are reversible? That you can reverse the symptoms, that the patient can go back to being a normal person?
So paraneoplastic syndromes can recur in 30 to 50% of the patients. Each time they recur, they make you more debilitating and invalid. And some syndromes, like what I told you, like the paraneoplastic cerebellar degeneration, they never recover. So some paraneoplastic syndromes have a high chance of recovery. The others, like cerebellar degeneration, they don't recover at all. They have a very poor prognosis.
Sir, when you talk about prognosis, can you tell us like an average or an approximate lifespan that these patients have?
So the disease will not kill you. That is the point, right? So now we have another patient who had ovarian cancer. She, after treatment of her ovarian cancer, she presented with paraneoplastic cerebellar degeneration. So no, sorry, she presented with paraneoplastic limbic encephalitis. Sorry, encephalitis. So she was always in some kind of a daze, altered sensorium, and all that. She is still alive after 7 years. But she can barely do her daily activities, get up from bed. She needs physiotherapy every day, barely able to walk. So it is not a disease that is going to kill you per se, but it will make you dependent on people. And what happens is, suppose it affects the respiratory muscles and all, it will lead to aspiration, choking, and instant death also, or death over a period of time. So lifespan is not the way we can count. What we have to say is, uh, certain paraneoplastic, especially the CNS diseases, can make you bedridden.
Sir, can you summarize today's session for our audience?
Paraneoplastic syndromes are seen in oncology practice. What patients should understand is it is not due to spread of the cancer. Do CSF analysis, do scans, do antibody testing to diagnose. commonly seen in small cell lung cancer, breast, lymphoma, thymoma. Bad paraneoplastic syndromes are like cerebellar degeneration, they will not improve. Treatments are generally treat the tumor first and also treat with steroids, high dose steroids, IVIGs, etc., as we discussed. Recovery happens in certain cases. Recurrences do occur in 30 to 50% of the patients. And have a high index of suspicion. Discuss with your doctor if you have unusual symptoms to the brain or the muscle, eye muscles, which are recent onset, then show your doctor to rule out paraneoplastic syndromes.
Sir, before we end the session, can you enlighten us about the second opinion campaign that you're running?
So, as you know, we are running a second opinion campaign. Patients or their caregivers can reach out to us on WhatsApp. We have the WhatsApp number put up, and we will reply to them as soon as possible if their reports are put up. This is only to guide them, and they can anyway continue treatment wherever they want. But this is just to guide them with the right kind of treatment plan.
Thank you for an enlightening session today, sir. We hope to see you again next Friday with another interesting topic. Thank you, sir.
Thank you so much.